All right, we're live.
Good morning. It is April 27th. This is the Senate Health and Welfare Committee. And today we're meeting to talk about a couple of things. One, we're going to look at some gubernatorial appointments and determine our process for reviewing those. And then we're going to come back to S-120 to look at some changes suggested as a result of its visit to appropriations. And then also another suggestion that I've been working on over the weekend and that some of the advocates have brought to us. So that's our full agenda today. So we'll start. Nellie, I think, have you sent out to us the list of gubernatorial appointments with the contact information?
Yes, I just sent it a minute ago.
Okay, so I think committee, if you open that up in your email from Nellie, that'll give the list and we can go through that list together and then determine how best to proceed, who would like to contact who on the list, and then our timing for that. Then Nellie will publish the list on our webpage. It's a matter of logistics before that happens. So just take a sec and go out onto your web page, your email, and I see it was mailed at 9:56, and there's a list of folks. So Nellie, are all of these people being appointed to a single board?
Yes, they are all being appointed to the Children and Families Council for Prevention Programs.
That's what I thought. So it's a Children and Families Prevention Program Board. I think it's an advisory. Is it an advisory committee? Did it say? Children's Prevention Programs. That's it. Doesn't say.
It's a
All right.
council.
There we have it. Could be a council. All right. So as I was going through the list, here's my thinking on this committee, what we've done in the past, and I think what serves us well is if you, I know a lot of people on the list, so I'm not going to take all the ones I know, but if there are folks that you know in your district who you would like to contact by email and then have a conversation, or you can contact them by telephone. That's sometimes easiest. And then confirm that they are interested in being appointed to this position if they've served before, and then any questions about their interest in the board. I think those are the three questions that you would like that we should ask them. So how many are there? There's 1, 2, 3. So there's 3 apiece. No, that was a bad division. So there are 5 of us and there are 9 names. So I would be happy to take Amy Davenport or Dr. Avila or Karen Vastine. I don't know if any of you know any of the people on the list.
I know Amy.
Amy Davenport, would you like to take her then?
Sure. Where am I finding the list?
It's in your email, Senator. It has it
In my email. All right.
And Nellie sent it out at 9:56, and it will. And the reason it's not posted is it has all their contact information. So we'll
Okay,
post their names.
I found
Okay.
it.
So
Yeah.
I'm going to keep a list.
'Cause I've got a whole bunch haven't happened in mine.
Yeah, I know. It's difficult when there's so many. So why don't I take Karen Vastine?
Where is the list that tells us what they're being appointed to?
there's nothing on the list that indicates that. Oh, you scroll down on the first email from Nellie dated Wednesday, April 14th, and you'll see that all appointments are for the Children and Families Council for
Ah, okay.
Prevention
I
Program.
think I did Amy for that 2 years ago.
Terrific.
Okay.
That's good.
Madam Chair,
Okay.
I'm wondering if Jen or Nellie has a description of this council, and are there statutory duties or anything that we should know about what this does, since it hasn't come up in testimony?
Yeah, we can look at that. I think for now, we'll get that information for you. It's in the green books. I
Okay.
think, yeah, so we can get that. Who would like to pick Maria Mercedes Avila?
I'll take the first two, Senator Lyons.
Okay.
If no one else
Okay.
knows them. I don't know them either, but.
I know, 'em, but I'm not, you're fine.
I don't know any of them, Senator Lyons, but just you assign me whoever you'd like.
Okay,
All right.
yes. Is there anyone there for you, Senator Hardy?
I know a couple of them, but I'm happy to take any of them. So if you
Okay,
want to just
so
go down the list and assign
I'm gonna
them,
go
that's
right
fine.
down the list. Don Hutchins, I'm gonna give to Senator Terenzini. And Doreen Dorfman, I'm going to give to Senator Terenzini. And then Senator Hardy, why don't you take O'Day and Pinkham?
Okay,
Senator Cummings, would you feel comfortable taking Henry Sparks?
Yeah.
Okay. All right. So the list is complete. Yes, we'll get
Reminds me, I
that.
have to send them out to my committee.
Yeah. I had intended to send you the list over the weekend and then started working on some other things. So that one escaped me, but I think we're good. And we'll get the description of what the group is doing, so that you're clear about that. And I think, Jen, this is a Katie, are you there? So the appointments for the Children and Families Council for Prevention is something that Katie works on, but we can dig that out of the green books.
Yes, I can look for that if you're going to move on to others.
Yep.
Can you give me the name again? Children and Family?
Oh, it's the Children and Families Council for Prevention Programs.
I found the description on the DCF website.
Perfect. Do you want to post that on our webpage as well? Please?
Yes, I can do that.
Perfect. Okay, good. All right. We're all set. Are you posting the link, Nellie?
I was going to post a single document with the description of the council as well as the list of appointees, if that works.
Yes, that's good. We'll start with that. And then if
Okay.
folks need to go further, we can work on going into Title 33.
Sure.
Okay. All right. Thank you all. There's, what would be the timeline on this? What makes sense for you as and given all of our busy lives right now? Shall we say Friday, not this Friday, but Friday next? So there's a 2-week period. I don't know what day of the week that is. It's May something. May 2nd, 3rd, 4th, 5th. 6th, 7th, 8th or 9th? Who has it? Senator Hardy, do you have it?
May 7th.
May 7th. I was all over the place with that one. Okay.
It's hard to remember.
So we'll try and target May 7th. We'll see what happens, and then we'll get together as needed so that we can report this to the full Senate, whatever the decision is. I know some of these people have been nominated for awards for their work with children and families. So it's a great group of people from my perspective. Okay. So committee, when Senator Hooker went into the Appropriations Committee, a couple things. We're going to pick up S-120 again and look at it. We never really finished the vote on it. We didn't have an official document because Senator Terenzini wasn't here, so that's actually a good thing. So when Senator Hooker went into appropriations made some suggestions for changes when they took the money out. They made suggestions that Jen will go over for the consultant, and so that we'll look at that. And then I worked over the weekend in communication with Blue Cross and Blue Shield and the FQHCs and hospitals on the PBM language that is of such concern to so many folks. And I think that those two differing groups and sides have come to resolution on their differences, and so have offered some language. How great. That's good. So we're going to look at that as well. And then as we go through the bill, there was one other suggestion that came to us from Blue Cross and Blue Shield. So we'll talk about that when we get to it. So just as an overview of where we are with S-120. So Jen, I will turn it over to you.
Great. Thank you, Jennifer Kirby, Legislative Counsel. So did you want me to put up I think we have a new draft.
Yes,
And
please.
also need to,
And then after we look at the bill, then we can talk about naming the bill as numbering the bill and whether it should be a committee bill or not. I've heard from members of appropriations and from the secretary's office that it might be cumbersome to put it in as a committee bill, and maybe we should stick with what it is. So as S-120. So we'll talk about that as well.
sorry, I'm going to pull this over here. All right. Can you see the document?
We can see that your name and the number of the document.
Okay. Does that mean you can see the whole thing, or you can just see?
No, we cannot.
the-
No, you
okay.
have to click on the link.
Hey, I
to
know.
get
Well, it's not working right today.
it. All right.
Nothing's working right today. Let's try this again. All right. Now can you see it?
Yes. Excellent.
Oh, good. All right. So this is the version that is done as a committee bill, but as Senator Lyons said, you can have that conversation about how you want to proceed with it. So I'll skip through. This is just the statement of purpose. I summarized the provisions of the bill. So for the most part, this looks like what you looked at last week, and except there are these changes recommended by the Appropriations Committee, or changes that they're recommending that you make to the task force. This is the Task Force on Affordable Accessible Healthcare. And so the first thing that they either would have you do, or I think they will do if you do not, is take the money out. They took the money out and put it into the Senate budget. So I was reviewing that document yesterday, did see the money in there. I think it should be in the H439 that is on the, I think on that calendar. So instead of having a specific dollar amount, which you'll see is struck through later, it would say, to the extent that applicable funds are appropriated in the FY22 budget, The task force, through the Office of Legislative Operations, shall hire a consultant. And then instead of saying to coordinate the task force's work, it would say to provide technical and research assistance, deliver actuarial analyses as needed, and support the work of the task force. And then the task force would continue to have the support of or assistance of the legislative offices.
So the language that they've put in there is consistent with the language that's crossed out at the bottom of page 7.
Largely. So there was this
Largely.
kind of duplicative language in here. Here's where the actual appropriation was. So this would come out, this whole subsection would come out because we've said, to the extent the funds are appropriated and the funds are being appropriated in the big bill. The language here had been the consultant coordinating the activities, which is the language you saw struck through in E, and to cover related costs of actuarial analyses, research, meetings, and the per diem compensation and reimbursement for members of the task force. The per diems are already included in this existing subsection H, which takes the money out of the funds appropriated to the General Assembly. So it wasn't necessary to have the per diem money also come out of this 175. So that was just a little drafting mishap. But so what would the language that would survive then would be here under assistance, and that would have this consultant providing the technical and research assistance, delivering actuarial analyses as needed, and supporting the work of the task force.
You're frozen. Uh-oh.
Rather
Uh-oh.
than just coordinating
Jen,
with funds being available. Yes.
no, you're good. You're freezing a little bit. You're going in and out. Maybe take your video off while we're going through it. I think there's too much going on. Try it.
Let me find my video.
Uh-oh. It's good now. Maybe it was
Okay.
just something.
Yeah, have been having some internet issues today. Apparently my internet is unstable, but maybe it's back. Can you hear me?
Yes.
Okay, great. So again, I was just trying to highlight the differences here. Instead of this language, this broader language about coordinating the task force's work, it has this consultant actually providing the technical and research assistance, delivering the actuarial analyses as needed, and supporting the work of the task force. In the earlier version, with the appropriation language at the end here in subsection I, the consultant was doing the coordination, but this money was also to be used to cover related costs of things like research, meetings, and otherwise. So that is what they are suggesting you include. And the other reason that we're looking back at this language again is because of that section toward the end of the bill that you had passed out, which I've now struck, but just put a little note in to remind us, which was the DFR benchmark plan review. They moved all of that language into the budget. And so they were asked that you delete that from your bill and have it ride in the budget.
So, and just FYI for everyone, I mean, obviously we knew that this would probably happen or could happen. And then I also received a note from DEVA asking that we put the primary care study into the benchmark plan, and it came in a little late. And now the benchmark plan is in the budget, so it's not something we can add here. So maybe the House or I'll get that message to appropriations to perhaps add primary care visits, cost sharing into the benchmark plan if the committee thinks that would be helpful. I think it'd be great actually, but.
So I think that would need to, or would likely be specific to the individual and small group market
Yes.
piece. You'd still probably want subsection B, which is the Green Mountain Care Board and others looking at the impact on the large group, including state employees and school employees.
Yeah, so, and I guess given where we are right now, we'll leave it there for now. And then if changes can be made during the H439 process or the process that this bill goes through going forward, we can, maybe that'll get shifted over. Just wanted the heads up on that one. So section A, you're saying, Jen, is the one that would go, yeah, okay.
I think it's right. I think it would be this subsection A that is specific to the individual and small group plans, or really looking at the qualified health plans, which is the focus of the benchmark plan review. So there's the linkage there.
Okay. All right. All righty.
Did you want to go then to the, I have not made any changes in parts so that you can have the conversation on the PBMs, but also
Do you have a copy of the language? I sent you the copy. Can you put that up from the FQHC and Blue Cross Blue Shield dialogue? And you're not coming through right now. Jen's gone.
Madam Chair, maybe we should have Jen not share her screen because that's
Yeah,
probably,
you're gonna do something like that.
yeah. Poor Jen.
Jen? She can't hear me. She's trying to get back here. It's like being in a black hole out in the universe somewhere. Okay. Jen Carby,
yes. Can you see and hear me? I switched networks.
now we can. You froze up.
I know. I
Completely.
tried. I've been having internet issues today, and I tried changing networks, and I think it worked, but it booted me off. So I had to come back.
Okay. So I don't know where we got separated.
I could
out.
still hear you. You just couldn't hear me. So I
okay.
have it by email. I mean, I have that language just in an email, so I can put it up
Okay.
if you want, just out of the email document.
Basically, what it does is it takes away the first part of the PBM language, and then it keeps this. I think it's the second part. I'm trying to remember each part.
Right. Yes. So it gets rid of D1 and leaves D2 and 3. So we renumber those.
Well, so it keeps the study in. That's.
And then it adds a study.
a
So the
study.
study is new. And I actually have a question about the study language. I'm just copying and pasting this into a
Okay. So we can look
standalone
at it.
document so it doesn't have people's names on it and such. Okay. Can you see that language?
Yes, we can.
Great. So as you can see here, the proposal is to, you don't see what is subdivision D1 in the version that we have been looking at, and it keeps the language of the other two provisions, D1 and D2. So a PBM shall not require a claim for a drug to include a modifier to indicate that the drug is a 340B drug unless the claim is for payment directly or indirectly by Medicaid, or restrict access to a pharmacy network or adjust reimbursement rates based on a pharmacy's participation in a 340B contract pharmacy arrangement. So it gets rid of that broader language that was sort of generally about not creating additional requirements or restrictions on a 340B entity on the basis of its participation in the 340B drug discount program.
So it's
Drug
much
pricing
more
program.
specific. It goes right to the specific.
Right.
Yeah.
And then it would require, and I would do this a little differently. I wouldn't codify this one-time requirement or effective date, but it would have DFR and the Attorney General's office report to the legislature on January 15, 2022 on possible state approaches to the developing issue of pharmaceutical manufacturers ceasing to pay rebates to commercially insured Vermonters. This is the piece I have the question on, because I'm not sure that they're paying rebates to commercially insured Vermonters personally for
No,
drugs
they're not.
dispensed by a 340B pharmacy. Any update to federal health and human services policy in this area and the financial impact to commercially insured Vermonters and 340B pharmacies of these changes. So I think we need a little bit more, I at least need a little bit more clarity on what the issue that they're citing of the manufacturers ceasing to pay rebates is
It
about.
sounds like they're trying to say, pay rebates for um, prescriptions available or paid for.
Well, I mean, the drugs that are dispensed by a 340B pharmacy,
Yeah.
the rebates or the drug pricing is realized, I think, by the pharmacy, which is affiliated with this 340B covered entity. I think the people who are working, who proposed the language are much more in the weeds on the 340B program than I am. So I'm sure they know what they're talking about. I just need to make sure that we're aligned in what we're understanding. So,
I'll leave that to you.
and then I'm also not sure these provisions shall take effect immediately and expire on December 31st, 2022, unless otherwise modified or extended. I'm not sure if this is a temporary provision, then I may change the way it's done altogether. We may just put it in session law. So I need to understand more. Just having the language by itself is not, it is not providing me with the full picture of what they're looking for.
There was a, oh, let me just, I got another email late last night that talked about the date of July 1st.
And Madam
Um,
Chair?
yeah.
Can I ask you a question? Who developed this language? Because this seems like it does a different thing than what the original language did.
It takes out the first very broad statement. This comes from a dialogue between VAS, the Bi-State Primary Care, and Blue Cross and Blue Shield. So it was sort of the, please go out into the hallway and come up with something that is less controversial on, so that this is a compromise. This is compromise language from those folks. And so that's it.
So, Madam Chair?
Yep.
Can Jen just clarify what this is going to do? I mean, as far as the pharmacists are concerned, the pharmacies and the drug prices for Vermonters, this isn't, I mean, when it says ceasing to pay rebates to commercially insured Vermonters, and I know that you said you needed to be clear on that, and so I need to be clear on it as well.
Yes, we need to get clarity on that. You're absolutely right, Senator. But the benefit of the 340B program is to have some access to prescription drugs at prices that are less than other places.
Mhm.
So the goal here is to make sure that that continues. The first
Right.
section that was taken out would have been not allowed any action on the part of PBMs. And this restricts what PBMs can do in a narrower way to access some of the savings. And that's really what it's about.
Okay.
Jen, do you want to can you, Jen, provide a thumbnail sketch of what is happening through the PBMs right now, and why Utah, for example, and why Ohio, why they're passing the bills that they're passing?
I don't actually have that
Okay.
information. I mean,
All
we
right.
didn't hear testimony on, I don't believe, on what problem the language is looking to solve, so I'm not able to articulate that.
Well, yeah, we did hear from the hospitals and we heard from Bi-State Primary Care, but their concerns were moderated by concerns from Blue Cross and Blue Shield. So the language here simply allows for for us to make sure that the savings are provided to the 340B pharmacies and to patients rather than to the PBMs. I think that's really what we're getting at. part of the 340B program for our FQHCs and other pharmacies is to ensure that there are some savings within the pharmaceutical pricing process, and that those savings go to the pharmacies or to the facilities that are 340B certified. And if you take all the savings away from them, then there can not possibly be a benefit to either the pharmacy, the 340B facility, or to the patient. That's it. Okay, Senator Hardy.
Thanks, Madam Chair. I guess I'm feeling a little uncomfortable with this because it seems to me, and I don't have the language that Jen just put up. Did you send it to us, Jen, or is it?
I did not. It came from an email that the chair had sent to me.
That I
Okay.
got late yet last night. So now that the language is up, can you send that? Nellie, you also have the language. Can you extract the language and post it on our webpage?
It doesn't seem to be trying to solve the same problem that the other language was trying to solve, or at least it seems incongruous with it based. And I'm a little, we didn't get that much testimony. We got the testimony sort of in passing within larger things. So I'm not sure.
Well, I'm concerned that if we don't say something about this and have an analysis going forward, that all the pharmaceutical savings that go to 340B facilities, including pharmacies and patients, will be under duress.
I understand that. I mean, I would certainly be concerned about that too, but it doesn't, the language that was originally proposed by.
It was much broader. You're
But
right.
it seems to be more about administrative stuff and that the benefit managers are requiring all of these sort of administrative hoops to jump through for programs participating in this, and that they were trying to get rid of those administrative hoops. And now the language, although I don't have it in front of me, seems to be more about, I don't know, payments maybe.
So if you look at what's on page 9 of the bill, as we have it before us, so create additional requirements or restrictions on 340B entity. So it's, that could be pricing, it could be rebates. I don't know what it is. I don't know what that it could be. It is very broad. Okay. So with that out, then Nellie, is that language up yet? Jen, can you put that language back up that we're looking at?
Sure.
So, number 3 on page 9 talks about restrict access to pharmacy network or adjust reimbursement rates. So that's a problem. Okay, so Jen, can you walk us through this one more time slowly so we fully understand what's here?
Sure. It says a pharmacy benefit manager shall not require a claim for a drug to include a modifier to indicate that the drug is a 340B drug unless the claim is for payment directly or indirectly by Medicaid. Or, do you want me to stop there?
What does it mean to include a modifier to indicate? Is it just
It's
like,
part of how they bill. It's so in addition to, it's something that indicates some sort of coding indicator that it's a 340B drug. So it's flagged as being a 340B drug.
okay,
And so I think the impact of this would be so that the PBM or PBM in this case would be paying claims for drugs without knowledge of whether they are 340B drugs or not. So without without reference to whether the pharmacy acquired them at a reduced cost because they were participating in the 340B drug pricing program.
Okay,
Except for Medicaid, that information is necessary and would continue to be included. And PBM also could not restrict access to a pharmacy network or adjust reimbursement rates based on a pharmacy's participation in a 340B contract pharmacy arrangement. So again, here, I think they're looking at getting the regular reimbursement amount and not some reduced amount based on 340B participation.
what is restrict access to a pharmacy network? What, do you know what that would mean?
I don't think I can
Okay.
answer that one.
Okay, so Madam
And then
Chair-
we would have, yes, do you want me to go into the report stuff or do you want to discuss these two?
No, I'm trying to get some of the advocates in who were working on this language
Great.
and invite them in. So I've asked Nellie to invite them in to the committee right now so we can have a broader discussion. So going back, restrict access to a pharmacy network, which it would seem to me that a pharmacy benefit manager can't move someone from one pharmacy to another. So if the pharmacy is a 340B pharmacy and it might provide lower cost drugs, the PBM may be getting a rebate or some benefit from another pharmacy. I don't know exactly how that would work, but that could be what is being restricted here, not allowing for the pharmacy benefit manager to direct the patient to a specific pharmacy, not a 340B pharmacy. So there's benefit to the patient to be at their 340B pharmacy. A PBM may be able to get some benefit from having that patient go to another pharmacy. That's what I'm reading there. But let's hope that we can get some of these folks in to help us further. So let's go to the report.
Okay, the report piece is that the Department of Financial Regulation and the Attorney General's Office would report to the General Assembly on January 15th, 2022 on possible state approaches to the developing issue of pharmaceutical manufacturers ceasing to pay rebates to commercially insured Vermonters for drugs dispensed by a 340B pharmacy. Any update to federal Health and Human Services, I think that's the US Department of Health and Human Services policy in this area, and the financial impact to commercially insured Vermonters and 340B pharmacies of these changes.
Okay. So, okay. Is there any question about that one?
Yeah, Jen, why would the AG's office be? What's their jurisdiction here?
I don't
Besides
know.
they're legal people.
I don't know. Again, not my language, so I don't know.
I know, I'm sorry.
No, it's okay. I don't know what the
I will
intent
say,
was here, except perhaps if they're concerned about anti-competitive behavior or something like that, but I don't know.
probably, and the AG's office has been very much engaged in looking at drug pricing and gets a report regularly about increased cost of drugs, especially for specialized drugs. There's a limited amount that we can do in terms of prescription drug costs, but the AG's office has been very much engaged in that over time. So that's, I guess, why that one is in there. That was my thought when I read it. So so now let's no, I know that the But a PBM may see a rebate, not the individual patient. Patients don't see the rebate. So let's take that one off. And here's my suggestion. I'm going to invite the people in who work together on this. And I keep getting my little messages. Patients have no clue what the price differential is, whether it's based on a PBM, an insurance, or a 340B, anything. That's not, the patient doesn't see that. The patient simply sees the copay or the cost overall. So this is about the internal functionings of the 340B facility and the insurance company and the PBM. So what I'm going to suggest is that we invite Helen Laban, Devin Green, and Sarah Teachout into our committee tomorrow, because we have some time tomorrow. I have deliberately, Helen Laban's coming in soon, so let me see what that message is. Hang on. So we'll hold here, and whoever can come in to help us this morning, that'll be great. And then if we can't get to closure on this today, we'll take a little bit of time tomorrow and look at it so we can finish our work on S120, apologize for that.
So
Senator
Senator
Hooker.
Lyons, thank you, Senator Lyons. So can we just ask those advocates who are coming in to clarify who this is helping? And
Yeah,
what it's going
definitely.
to do?
Yeah, definitely.
Yeah, okay.
That's the primary question, we want to make sure. The problem with this one is the 340B program is meant to help patient access to prescription drugs at a lower price, and through the federal 340B program. But there may be some loopholes that allow for the money to go different places, and PBMs have
Without passing through to
yeah,
the
so it gets to be more and more complicated the further along you go, and then you start talking about how do we price prescription drugs and on from there. And we haven't looked at that, or at least some of us haven't. The committee hasn't seen that recently, so we may want to pick that one up at some point. So
Madam Chair, are we doing tomorrow the joint session?
that's Thursday.
Oh, it's Thursday. Oh, I had in my mind that it was tomorrow with
No.
judiciary.
Thursday.
Thursday, okay.
I deliberately put a day between today and that one, just so we could do anything we needed to on the bills that went to appropriations. And so Thursday, while we're discussing it, is a joint meeting with the Judiciary Committee on a bill H225 on buprenorphine, low quantities of buprenorphine. And so I've been working with getting testimony for that, and Senator Sears has been getting testimony for that. So we'll have that day together. But for this one, Jen, I think there's another section that we should look at, and that is an ask from the insurance companies, actually from Sarah Teachout from Blue Cross and Blue Shield, about the administrative expenses report, indicating that it's an unnecessary request. So when she comes in, we'll ask her to go through that with us as well. I just this morning received an email from her about that. So committee, let's take a break until 11 o'clock. And we'll see if Helen Laban joins us, or if Devin Green or Sarah Teachout join us. And then we'll pick up at 11 where we are right now. Okay.